Hi, my name is Atif Darus, professor and consultant of obstetrics and gynecology. In our practice, commonly we can see during transvaginal ultrasonographic examination some pictures of the ovarian cyst, which seems to be ovarian endometrioma. In such a case, what to do for treating this case and what to tell your patient about the finding of ovarian endometrioma. This is the main topic of this lecture. Of course, we know that endometriosis classically is defined as chronic gynecologic recurrent heterogeneous and complex disease characterized by ectopic endometrial tissue outside the uterus and is thought to arise by retrograde menstruation or other theories. And we can classify the phenotypes of ovarian endometriosis as typical or atypical. And typical may be superficial peritoneal endometriosis or deep infiltrating endometriosis or ovarian endometriosis. And ovarian endometriosis can be classified into two types when you find by laparoscopy some ovarian nodules or ovarian spots of endometriosis, this ovarian endometriosis. But deep ovarian endometriosis is the ovarian endometrioma, which is the topic of this lecture. Of course, diagnosis, as I already mentioned, is based on ultrasonography. During ultrasonography, you can see this picture of ground glass appearance of the ovarian endometrioma with characteristic appearance. And sometimes you can use dynamic transvaginal ultrasound, which is mapping to see if there is adhesion to the colon or a sliding test to see if it is densely adherent or not. And this is an important test for surgical intervention if you decide to do laparoscopy. And actually, the transvaginal ultrasonography as well as MRI now replace the standard laparoscopy as a first line modality for diagnosing ovarian endometrioma or even endometriosis in general. Nowadays, ultrasonography and MRI are replacing the role of laparoscopy. So we don't have to rely on laparoscopy. Don't rush to laparoscopy because you have a good tool, which is transvaginal ultrasound and dynamic transvaginal mapping, in addition to MRI in some cases. By this way, you can avoid doing laparoscopy, which is a major operation with anesthesia. In short, we can classify the topic of this lecture into gynecologic perspective of endometrioma as asymptomatic. Sometimes we have four types of patients. We have four types. When you see endometrioma by ultrasonography, the first question is to ask yourself, is this patient symptomatizing or not? If she is not symptomatizing, she is asymptomatic. And I discovered this ovarian endometrioma by ultrasonography incidentally. And there is controversy regarding surgical management of endometrioma in women with an incidental finding, as recommended by the British Society recently. So if you see endometrioma by ultrasound without any symptoms and just incidental discovery during ultrasound, don't rush to surgical intervention or even hormonal intervention. And you have to make follow-up visits, just follow-up. You tell the patient that I found an endometrioma and it's small, and you have to follow up every 3 to 6 months by ultrasound to see the size increase or stationary or decrease. And also we have to follow up by the ovarian markers, which is AMH, antral follicle count, to see if it is affecting the ovarian reserve or not. This is the protocol for asymptomatic endometrioma. This is the first group of patients. And mind you that if you try to do excision or treatment of an endometrioma in an asymptomatic patient, with low AMH as low as 1.17 nanogram per milli or intrafollicle less than 7, this is not good. This will destroy the ovarian reserve and is not routinely recommended as recently published, of course, after exclusion of malignancy. So asymptomatic cases should be offered expectant management, no surgical intervention or even hormonal intervention. Just serial ultrasound to see the size and to see the intrafollicular count, hormonal AMH every 6 to 12 months or 6 months according to the patient's age. But if the size is big, 4 centimeters or more, we have to evaluate the patient that if she is a high-risk patient or low-risk. High risk for what? For ovarian failure or ovarian destruction. Those with low antimullerian hormone, low intrafollicular count, previous surgeries, or bilateral. In such a cases, it's better to postpone surgical intervention and to go to hormonal and treatments because the surgical intervention may have a deleterious effect on ovarian reserve. All the time you have to exclude malignancy. This is the first group which is incidentally discovered. The second group is infertility. You are doing ultrasound for an infertile patient. She is searching for a cause of infertility, and when you are doing ultrasound, you see endometrioma. The first question from the patient, is this endometrioma a contributing factor for my infertility or subfertility or not? Yes, it may be a cause due to adhesions, anatomic distortion, altered ovarian functions, endometrial receptivity changes, decreased ovarian reserve, some inflammation associated with endometriosis with increased release of chemokines and cytokines, in addition to dyspareunia and systemic manifestations and psychological problems. So it may affect your fertility. Also, the endometrioma can affect the ovarian, the oocyte quality and embryo quality by affecting the follicular fluid, the cumulus cells, and the oocyte itself by different mechanisms. Okay, the patient knew that this endometrioma can affect her fertility. What you will do for treating this case? The management is divided into 3 groups: management for natural conception, management for ART, or management of infertility plus pain or abnormal uterine bleeding. These are the main groups of treating infertile patients. So you have to ask yourself, my patient is coming for infertility alone or infertility with pain and abnormal bleeding? She is coming for infertility seeking for natural pregnancy, or she is planned to do IVF or ICSI. These approaches are important to decide the plan of management. So if the patient comes with other symptoms like severe pain, this goes with doing laparoscopy to treat the cause of pain and to destroy the endometriotic lesions other than endometrioma, because this patient usually has dense adhesions and so on. So in such a case, if there is pain, it's better to go to surgery. But if the patient's age is high, or the patient is approaching menopause or 40s or 35 or more, it's better to avoid surgery as much as you can due to possible effect on the ovarian reserve, particularly if they have borderline AMH, intrafollicular count, and previous stimulation cycles before. If there is a risk of cancer, you have to go to surgery. In such a case, the risk of malignancy is determined by appearance of solid components inside endometrioma, locularity, echogenicity, irregularity of the shape and wall, safety inside and locations, and the presence of peritoneal ascites. All these are sonographic manifestations suggestive of possibility of malignancy, in addition to rapid growth on follow-up. these criteria go with favoring to go to surgery to take this cyst out for biopsy and further management. It's not a matter of expectancy in such a case. If the patient has a previous surgery, this is not good to do another surgery because every surgery will have a deleterious effect on ovarian reserve. So previous surgery goes to ART, not to surgery. If it is bilateral, the same. You have to go to ART, not to surgery. If it is unilateral, you can go to surgery because the other ovary is good and functioning. And of course, the size is big, you have to go to surgery. Too much big size is better to go to surgery. Prolonged infertility, you have to go to ART, not to surgery. And these are the possible selection criteria for which approach you have to go to do either surgery, either natural conception or ART based on these findings. So for natural conception, the patient is offered natural conception despite having an endometrioma. Why? Because the evidence that the impact of endometrioma on spontaneous conception is limited. 43% of spontaneous pregnancy rates during the 6-month follow-up period in the presence of unilateral endometrioma reaching up to 5.3 plus minus 1.7 centimeters has been proved in a prospective observational study. So you can offer your patient who is waiting for natural conception, provided you make follow-up of the size, image, and so on. But sometimes patients say, I need to do surgery. Is it possible to do surgery? Yes, you can do surgery, and this is advantageous because surgery will restore pelvic anatomy, will lower the risk of recurrence with less endometriosis-associated pain, and of course, it needs high experience. But mind you that surgery may affect the ovarian reserve and is not believed to reverse the inflammatory and biochemical change associated with endometriosis, and it remains unclear to be beneficial. But we have another case. She says, I am planning to do IVF. In such a case, it's better, as recommended by all societies, including ISHRI and others, to avoid surgery as much as you can. Don't do surgery except in some certain indications. What are these exceptions for doing surgery? When the endometrioma is a cause of failure to access the ovaries to make OBU. In such a case, the endometrioma will push the ovary away from the field or the scope of transvaginal ultrasound. You cannot collect the oocytes. In such a case, it leads to anatomic distortion of the pelvis. So you have to do surgery to facilitate the access to the ovaries. Sometimes the endometrioma is ruptured or infected at the time of egg retrieval by the needle. So in such a case, you have to go to laparoscopy to aspirate this fluid and endometrioma fluid and to remove it. Also, the patient may develop severe pain after induction of ovulation, which is endometriosis, ovarian stimulation pain, or she has already pain in addition to infertility, or there is suspicion of malignancy by the ultrasound as I already mentioned. If she is planned to do IVF, you can do any stimulation protocol based on long agonist protocol, or you can use antagonist protocol, and there is no difference between the results regarding the pregnancy rate and if we compare long protocol to the short and to antagonists. So the protocols are more or less similar, comparable outcomes, but the antagonist protocol has safer results as mentioned by some studies. So we have to know that ovarian endometrioma per se, without any intervention, without any medication, has a negative effect on ovarian reserve and fertility. But if you do surgery for this ovarian endometrioma, this may further aggravate the condition due to a bad injury to the ovarian parenchyma. So the key of success for treating ovarian endometrioma is to check anti-Mullerian hormone level, follicle count, before and after the procedure. If the patient is low risk, which means normal AMH, normal follicle count, no previous operation, unilateral, you can go to cystectomy by laparoscopy, which is advantageous. It prevents recurrence and alleviates pain or relieves pain completely. This is a good achievement, but it may have a deleterious effect on ovarian reserve. But if the patient is high risk with decreased antral follicle count, anti-Mullerian hormone, previous operation, bilateral cases, in such a case, you can do surgery, but alternative technique, not to do cystectomy. You can do uh, opening of the endometrioma, drainage of the fluid, and ablation of the wall with bipolar diathermy, laser, or whatever. And sometimes you can inject sclerotherapy inside it. But you have to know that the recurrence rate is high in this group if compared to cystectomy group. And of course, cystectomy is done by opening the endometrioma and drainage of the chocolate material from it. And then you have to dissect the cyst wall to remove it from the ovary. And if you are in the correct plane, the cyst comes with you easily and you can extract it in a way like this case easily. And you have to control any bleeding at the bed. Some studies use combined technique, which is combined stripping or peeling off of the cyst, in addition to coagulation of the hilus with bipolar diathermy or laser to avoid damage of the ovarian stroma. So you can use stripping technique alone or combined stripping plus ablation together. And ablation is another approach, as I already mentioned, and sclerotherapy with higher rate of recurrence. So the surgeon should be trained in different surgical techniques, types of diathermy and hemostatic agents that can minimize the risk of inadvertent injury to normal ovarian cortex. The third group of our patients may come with pain alone or pain and infertility. If she is coming with pain alone, with mild to moderate, you have to consider empiric treatment like COCs, like analgesics, painkillers, and so on, progesterone. If it is moderate to severe, you can go to laparoscopy to surgically excise the mass and ablation of lesions at isolysis. And if recurrent, you have to go to hormonal treatment like Diagnostic and others. But if she is coming with pain and infertility, of course, you don't have to give hormonal treatment in such a case because hormonal treatment is given for patients who do not desire to have baby. In such a case, it's better to go to laparoscopy to alleviate or relieve pain in addition to increase the chance of having pregnancy. If the patient is coming with excessive bleeding, abnormal uterine bleeding, hemorrhage, metrorrhagia, or whatever, in such a case, you have to go to hormonal treatment as a first line, in addition to some supportive treatment like tranexamic acid and others. And these are the hormonal treatments commonly used, which is first line treatment. We can give combined oral contraceptive pills. You can give progesterone alone, Diagnostic or norethistyrone acetate. And some studies found similar efficacy on pain and recurrence if you use the cheaper norethistyrone acetate compared to the more expensive Diagnostic. But of course, Diagnostic has been studied too much compared to norethistyrone acetate in endometriosis, and some studies found it has a good effect on preservation of ovarian reserve. In previous years, we were using danazole or danocrine, which is androgen analog. Nowadays, not used because of androgenic side effects and bad effect on the liver. Also, we can use GnRH agonist or antagonist. Agonists make down regulation, decreasing receptors in the pituitary gland and endometrium regarding the receptors for GnRH. But the antagonist blocks the receptors, and the number of receptors is similar, and this competitor antagonism to the GnRH with immediate block of the gonadotrophin release from the pituitary gland. And nowadays there are oral gonadotrophin releasing hormones, which are nowadays are considered alternative when first line medication do not work. And the oral GnRH antagonists include elagolix, rilugolix, and linzagolix. And linzagolix is advantageous as it doesn't need add back estrogen and progesterone therapy, unlike elagolix and rilugolix, which need add back therapy to minimize hypoestrogenic status caused by the immediate blocking of the receptors. So the recommendation is nowadays is with linzagolix. So in conclusion of this short lecture, I would say that modern endometrioma management should be individualized, patient-centered, multi-mode care pathways, call for improved education and awareness. All patients with ovarian endometrioma should be offered an individualized, shared decision-making approaches informed by clinical history, symptoms, fertility status. As I already mentioned, we classify our patients into 4 groups according to the group. Women planning to undergo ART should not be subjected to surgical treatment of endometriomas with some exceptions, as I already mentioned, and this is a recent recommendation by the ISHRI. Even in women with initially normal ovarian reserve, close monitoring is recommended in the presence of endometrioma by AMH and intrafollicular count, particularly in those of advanced age. Ovarian reserve tests should be considered before any ovarian surgery and after ovarian surgery and can help guide the patient towards the optimal treatment. Women with endometriosis who are considering fertility preservation treatment should be offered an opportunity to discuss the reproductive planning. And this is important because the patient is known to be endometrioma patient. Don't leave her to lose years of her life without advising her to have ovarian cryopreservation to be in the safe side if the ovarian functions are deteriorating. And thank you.